So good evening to one and all present here today. We would like to thank IWN and especially Dr. Mohan Shenoy sir for accepting the invite to talk about the management of diabetes in women, which is predominantly very much important topic to discuss in current situation. And now I would like to invite Ms. Radhalakshmi ma'am to give the remarks. Thank you.
Thank you, Soumya. Happy evening to one and all. It's a great all present here. It's a great privilege and honor to welcome the members of Indian Women Network, IWN TamilNadu, MedPiper, JournoMed, Dr. Swash, and Sri Gokulam Medical College and Research Foundation. Special thanks to our speaker, Dr. Mohan T. Shenoy, for accepting our invite and being with us today for this delivery session, Management of Diabetics in Women. About our speaker, Dr. Mohan T. Shenoy has completed his MBBS, MD, and DM endocrinology and is a practicing consultant endocrinologist in Sri Gokulam Medical College and Research Foundation, Trivandrum. His major achievements include editorial board member, thyroid research and practice. Reviver is an international journal of diabetics in developing countries and in IGEM, a recipient of Nagoji Rao Memorial Gold Medal in MBBS, Chief Promotion Coordinator at ESI Con 2017 Trivandrum. His publications include first author of 2 chapters in ESI Manual of Endocrinology, second edition 2015. He has presented multiple papers in national and international conferences. His research interests include HCV-related metabolic syndrome, diabetics, pediatric endocrinology. He's a life member, Endocrine Society, PCOS Society, Indian Thyroid Society. Looking forward for an informative and insightful session, Doctor. Over to our speaker, Dr. Mohan T. Shenoy. Thank you.
Let me just open my screen. Yeah. So I thank the team for having invited me. I think this is an honor for me as well because I have been following the programs. I've seen a few programs as well. I think the initiatives is very good. I think the way people are also focusing on diabetes, it's also one of the major keystones. So because nowadays we are technology era, I think the webinars have actually helped us in understanding many aspects, and this is one of the ways in which we can connect to all of you. So as I just get my screen ready. So today I had a clinic which was not compromising with me, so I had to just because I don't have a team to take care when I had a OP, so I just had to be for some time there. That's why I got a bit late. Yeah, so I just finished loading it. So basically it's on diabetes. I think we are having a team, we are having more of the medical, or we just wanted to help because to know the people, audience logging in. Soumya, can you just tell me whether we have that doctors or we have a mixed pool? Do we have what is the predominant number of
we have right now we have more doctors and less corporates, and I think they have joining one by one. I will update you, doctor. Maybe 50 minutes I will update you.
Yeah, so that's what the basically I will focus on the management aspect. So this will be more relevant for the practicing people also. So I think that's what we are going to do. So just got the slides now. The slides were loaded, but I think the screen went offside. So how much episodes have you been through? I just wanted to know, you have been through doing these programs. So how many episodes have you already completed?
Yes, as of now, we have completed with the breast cancer.
Okay.
We have completed bone health and chronic pain management in women.
Okay. Okay. Already you have covered one by one in women's health. Okay. Okay. That's great.
Now we wanted to focus on
diet. Yeah. So that's what I just wanted to. So yeah, I'm done. So my screen will be opening now. Just give me a cue when the slides are visible to you. Now I think it's on. Has it come now?
Yes, doctor, you have to keep it in slideshow.
Yeah.
Done.
Yeah. So Dr. Rajapal sir has already come. Dr. Ramesh sir, hi to all. So greetings from Sri Gokula Medical College, where I am working here as a consultant. So today we'll be talking on diabetes in women, which is one of the major aspects of diabetes in our part of the region, because as you know, women's health is also a priority, as we have already been seeing. So once again, thanks to the team for having me here. Yeah. So the relevance of this topic, before starting the topic, I think I was informed that there was a lot of entrepreneurs also in this team of listeners. So this will be like less of medical English, and I will focus on more of practical knowledge and awareness. So my agenda will be focused on the scientific aspects of women's health and diabetes management. Management includes also prevention and diagnosis and treatment. So this is the contents of my discussion. I will focus on the definition of diabetes and the background of diabetes health in women, and why this topic is very relevant and important in our context. Then coming to the specific considerations in this aspect. So we'll focus on a few important areas of concern. Also to focus on preconceptional care or preventive endocrinology, how this is a very important to know from the practicing persons or the person who is living with diabetes also. And ultimately regarding the management strategies, how we can derive the knowledge in this field. So there is a lot of evidence which has been accumulated over time, last 1 decade, on how diabetes is different, more difficult and more distressing, as well as having larger mortality in women. So the lifetime risk of diabetes is very high in women, and basically it's not just because of hormones. There are many other social reasons as well why this happens. The prevalence of diabetes in young women is also alarming, because the people with PCOS, polycystic ovary disease, obesity, overweight, as well as infertility is also there. So pre-diabetes in young women is alarming numbers, and they convert to diabetes as time goes with age. So women with the reproductive age group, or from 15 years to 45 years, with pre-existing type 1 or type 2 diabetes, which I will tell what are they are having unacceptably high risk of pregnancy complications. They include weight loss, pregnancy loss, preterm deliveries, and also delivering babies with serious birth defects. So this is also called glucotoxicity embryopathy. That means when glucose levels are high, it becomes toxic. And when this embryo, the child who is growing, it's affected, it causes embryopathy. So this is what we call. So by definition, diabetes mellitus is a group of metabolic diseases, and they are characterized by hyperglycemia. So I will just focus on each aspect where as time goes. There are defects from insulin secretion also, as well as insulin action as well. So that is why type 1 is called secretion defects. Action defect is type 2, or there can be mixed type, like in gestational diabetes, both of them can be defective. So whatever they say, the chronic effects of diabetes, we all know they has got long-term damage to tissues. Damage means the tissues got destroyed, then slowly dysfunction or function gets lost, and then failure happens. So these organs include the vital organs like the eyes, the kidney, the heart, the nerves, as well as the blood vessels. We call them by various pathies like retinopathy, nephropathy, neuropathy, cardiopathy, that is cardiomyopathy or CAD, coronary artery disease, as well as vasculopathy or blood vessels. This graphic gives you the various types of diabetes. So this I just got from the net. I think this is very much important from us, because it simplifies the way we think about the types of diabetes. Type 1 means the body does not generate sufficient insulin for regulation of glucose. Type 2 means there is insufficient insulin secretion for blood glucose regulation. Because we are in the modern medicine, modern science, we have got tools to find out type 1 diabetes or type 2 by several tests like antibody test, C-peptide test, which is actually beyond the scope of this topic. Then we have got gestational diabetes. That means in pregnancy, towards the middle or early part, the body is not able to produce insulin. That means there is a mixed features of type 1 as well as action features of type 2. So whatever said and done, the symptoms of type 1 and type 2 are almost similar, like always hungry, there is a loss of weight, unexplained, unexpected weight loss, numbness of feet or hands, they can frequent urination. Also noting that there are sexual disorders, sexual issues which can happen, extreme fatigue as well as thirst. And ultimately, we all know people can have wounds which heal slowly and they'll end up with a lot of other complications which I already have told you. Last 2 years, there are so many data regarding corona epidemiology, but just to show this term is very familiar to all of you. Epidemiology means the disease study, which means the prevalence or the occurrence of that disease in the population, as well as the number of adults. So this is the data which has been published by the WHO from the last many years. So there has been exponential rise in the numbers of diabetes from 4.7% to 8.5% overall. That means that in women also we are having a similar rise in the figures. 2 out of every 5 women with diabetes are reproductive age group. That is a productive age group. That means at least 60 million women worldwide. Gestational diabetes is any glucose intolerance or onset or recognition during pregnancy, and it develops in at least one of among 25 pregnancies worldwide. And this data is alarming because in India alone, at least 4 million of women have got gestational diabetes. So when pregnancy has diabetes first diagnosed in pregnancy, that can be gestational. Even those initial can be overt because already had diabetes before, but only recognized because they went for checking. That can also happen. Approximately 50% of them will undergo and lifetime, they can at least develop type 2 diabetes within the 5 to 10 years after delivery. So it is unpredictable. So which is why we should always screen them at least annually every 3 years. So regarding the data, again from various continents, so these tell you that there is a steady catch-up numbers of women and women with diabetes. Initially, there was an excess of 16 women, and we are seeing that as time goes, the numbers with the barriers will narrow down. And now we are seeing that a projected number is also going to very high levels in amount of population. So criteria for diagnosing diabetes is value of fasting glucose or fasting blood sugar of 126 milligram per deciliter or above as per the ADA criteria. There are various criteria of WHO, the AAC, RSSDI, so many criteria are there. This is a simple, straightforward criteria. 70 to 110 is the one we usually tell in the lab, but this is the standard CDC ADA definition. Pre-diabetes also we are seeing 100 to 125, and those with pre-diabetes can convert to diabetes in at least 20% time, in about 2 to 3 years time. Normal, there is a test called HbA1c test, which measures the load of glucose contained in the hemoglobin, and this is very predictive of the pre-existing diabetes control. That means when diabetes is not under control, the diabetes value can range from 7% to 12 or more than that. So higher the level, that means the poor control is there. So we want to have an HbA1c of less than 6.5. So there is a type of diabetes called type 1, which is more common in children. And there is so many years, so many data. So we are celebrating the 100 years of insulin discovery. So insulin is the only treatment possible in type 1 diabetes children. So as diabetes is well controlled, they actually progress towards adulthood. And we are seeing so many children who have gone into adulthood and become mothers and having successful lives ahead. So type 1 diabetes is no more stigma. If we diagnose correctly, if we manage appropriately, they can also have an event-free survival. But now, at least last few years, research is on for the cure of type 1 diabetes also. So complications of diabetes is also there in pregnancy as per the gestation. So gestation means the time in the child in the mother's womb. So a type 1 diabetic individual can have more complications because of the load in the sugar in the bloodstream. And we are seeing that so many issues are happening throughout the pregnancy. So pregnancy is just like the treadmill test of the cardiology, because when we subject to treadmill test only, we know how the person fares there is always a scare in going to treadmill, unless of course we are in the gym. So a treadmill test is similar to that we are seeing in pregnancy, because pregnancy, the glucose tolerance is worsened in this period, and we are seeing so many times that those who are previously well controlled pre-diabetes can have very high glucose levels, because the growing child requires the nutrition. So this is why we should know that when a type 1 diabetes is already diagnosed and progressing, HbA1c percentage has to be kept in the control range of 6.5 or below before they can contemplate pregnancy. This is to prevent the fetal damage. This is the different damages that occur. Even the baby is at risk of diabetes, obesity, metabolic syndrome. And we are knowing that so much data has come regarding the type 1, type 2 diabetes progression also. So complications are divided into microvascular complications like retinopathy, nephropathy, and neuropathy, and macrovascular complications like cerebrovascular disease or stroke, cardiovascular disease or heart attack, and peripheral diseases or circulatory damages. So these diabetic damages are more often preventable by proper screening, which is why annual we should do an eye checkup. At least 3 monthly we should do the labs for the glucose, and at least 6 monthly a creatinine test. So the person who is properly aware and tuned about the complications will himself or herself do that, which is why we call self-empowerment. So this slide is a very illustration of the drivers of diabetes. So diabetes can be driven by various contexts, because we are seeing now that pregnancy also that time can be diagnosed. It can be overt pregnancy diabetes, or it can be gestational diabetes. There is also something called polycystic ovary syndrome, where ovulation does not happen on time. And this can also be a reason for insulin resistance. We are seeing menopause also contributing to this because of the hormonal problems. And we are seeing so much disturbance in the glucose control post-menopause, because the protection of estrogen is lost during the menopausal period. Obesity is one of the major pandemics which is correlated, and we are seeing sedentary lifestyle is one of the major reasons. There is also urbanization and globalization, which we cannot prevent, because there is no village now. It is always, India is itself gone like a city now. So we can see internet available in every village. Most often current is available. So facilities are there available most often. So India has become like a global hub now. So technology is helping, but now that is why even children also can have type 2 diabetes in early time because of this risk. So quality of life improvement has itself issues happening. Despite all these, there are also healthcare disparities. Healthcare system in India is adept, but only to an extent. There is also financial dependence. So many diseases still don't have insurance covers in the OPD's context. I know a lot of practitioners are joining today. So they all agree to me most often that financial dependence is a very important context. Having a woman with diabetes and man with diabetes may not be important in a textbook context, but in real world context, if a person is earning and the person's wife has a diabetes, they definitely may have, they may tell the person that you may have to compromise on your medicine sometimes. You may have to buy some less costly medicines because there is a bread earners issue. So now I think these disparities are slowly going away because of the awareness and improved quality of the treatment plans. Also, generic medicines are available, which means the same medicine can be given at a lesser cost. And we know the stress element, everybody is going through the stress. I think a few minutes back, I was in the stress of reaching correctly on time. So we are all having stress. We cannot avoid that in our lives. And stress is the thing which we have to live with. I have seen some persons who have got diabetes just because of sleep deprivation and work stress and not able to balance their work-life balance. So stress can happen, physical stress, emotional stress, all other stresses, and they can all contribute to diabetes because of the oxidative damages. Then comes to the genetic aspects, because we know that the previous generation was healthier and they had less diseases than our generation. And genetics has an important role to play in that, because the previous generation, the health aspects, they used to be very properly monitoring. And when they had diabetes in the old age, now we are seeing diabetes skipping generations and coming quite earlier than the previous years. So this means there is a generational shift happening in diabetes also. Then comes to two important aspects I want to tell in the end. They are the low birth weight or small for gestational age and the caregiving phenomenon. The low birth weight means a birth weight of less than 2.5 kilograms or intrauterine growth restriction. So within the uterus, the baby doesn't grow well. That can itself cause a lot of malnutrition issues, and this can damage the blood vessels of the growing child, and this calls maladaptation. This is called developmental origins of adult disease, or DHOAD. This is called Barker hypothesis. This can be the forerunner towards diabetes also. I have seen so many cases where diabetes in the children also occurring because the birth weight was high. The body weight of the birth weight of the child at birth was 4 kilograms. That can be the opposite side of it. That also can lead to another type of type 2 diabetes. Caregiving, because we know when we come birth, the mother is the person who is affectionate. I don't say the father is not, but more often the gender role is given to the mother. So caregiving aspect is a very important aspect, which I think we all familiar. And caregiving is a very compassionate, affectionate role. And definitely when the person gives care, the person also grows. But this aspect has been also shown to be the driver for diabetes. So taking care of others before taking care of themselves. That is why caregiving is an important aspect. So this is why we have to understand women diabetes more. We have to overcome the gender specific issues. We have to understand difference correctly. There are many predetermined aspects, how to intervene them at right time. And all these medicines which modern medicine prescribes, and got the cardiovascular safety studies being done. So which is why we should understand which drugs can be used safely in these women. And also which treatment should be treated differently. And how can we bring down their mortality or morbidity issues. Coming to obesity in women, obesity is also one of the risk factors for type 2 diabetes. It negatively impacts the health. It increases the risk of diabetes and coronary artery disease in women. And in the several years which we have gone through, the childbearing age, these women have got more issues because of so much of body weight accumulated. And overt diabetes is actually increasing in frequency in the younger population, in the asymptomatic people, as well as the polycystic ovarian syndrome. So gestational diabetes in the pregnancy and the future, if they are gaining weight steadily, they can also be termed risk factors for progressing to type 2 diabetes. So I had already told you about the Barker hypothesis, maternal undernutrition leading to fetal growth restriction, leading to structural change in the organs, and this can lead to the childhood growth retarded as well as metabolic endocrine dysfunction. And when they go to school or later in life, they can have some other issues which can be hypertension. This can have dyslipidemia. They can have also diabetes. So we are seeing both undernutrition and overnutrition as bad. So this is why we have to focus on the right aspect and preventive aspects. Coming to polycystic ovary disease, it's also important because we are seeing this diagnosis also getting more discovered by ultrasound scan, by the gynecologist, also when they come for the black color over the neck. So this is called insulin resistance. So high insulin levels in the circulatory pool, this can be a risk factor for progression of these complications. And we know there is a production by the liver, which is called sex hormone binding globulin. There is also something which we all know regarding the ovarian androgen production, because ovaries also produce a small amount of hormone called androgens. And this is the reason why they have the features of hirsutism or increased hair over the face and the neck or over the beard area. They're also having disorders in the hypothalamus area because LH-FSH is the hormone for the release of the ovary axis. So when they are not properly happening, they can lead to less ovulation frequency or not happening or anovulation. So all extremes can happen, and ultimately high body weight can also be the forerunner or the co-runner with these conditions, which is why we should always review the records when a polycystic ovary disease person diagnosis with diabetes. Also regarding cardiovascular risk, we also know that premature menopause or earlier than usual menopause, gestational diabetes hypertension in pregnancy, preterm delivery, all these aspects, polycystic ovary, they are all sex-specific risk factors. Well-established risk factors, no doubt about that. Hypertension, obesity, unhealthy diet, suddenly don't need any person lecturing you for that, but this is very well-established risk factors. And I also want to focus on under-recognized or less understood factors, which are psychosocial risk factors. Also regarding the abuse, because we have also encountered people who have reported sexual abuse or intimate partner violence. They are also a risk because they can cause depression, anxiety, and all these risks for the gender influences. Socioeconomic deprivation, because the financial aspects, because they have to go for work, and after pregnancy, we all know there can be so much issues which can delay that. Also literacy, because though they're literate good, they may not have the health literacy, because we are seeing very good qualified persons coming to our clinic, but the knowledge of the disease or over knowledge also happening, but without the proper health aspects. This can also be a danger for the person. Over active on social media may not be literate on all the health aspects. Regarding environmental risk factors, so much research has been now showing even air pollution can be a risk. Smoking can be a risk for diabetes also. Which is why International Diabetes Federation has every year come up with interesting themes. 2017, the theme was women and diabetes, and this is why we are focusing, because so much numbers are going to increase with time, and we are also seeing that it's a major cause of death among women and higher risk to have heart disease and miscarriage or having malformations. So solution to this all is making them more aware, like these sessions are happening today, giving them proper access to medicines, and also teach them about self-management, because information is a tool now, and this is one of the things which we can address in the long run. So ultimately the aim is to act today to change tomorrow. So regarding the sex differences and the body fat distribution, so we are seeing a graphic of the various distribution in the male and female. So as time goes, the visceral adiposity is more in the males, whereas subcutaneous fat or below the skin, that fat is more in the female section. So this is an important aspect, because fasting glucose elevation is more seen with the male counterpart because of this aspect, and also the postprandial glucose or the glucose tolerance aspect is the one which is important for the diagnosis in the gestational diabetes. And this is the bioinformatic model, which shows you that in the male population, the increased fasting glucose is contributed by the increased skeletal muscle mass, increased visceral adiposity, increased ectopic fat or fat deposits outside the normal distributed area, also the fatty acid oxidation at rest. And we are seeing that the body fat mass is distributed in the opposite side in the female. We are seeing that they are having total fat mass which is increased, and the increase in the subcutaneous adiposity is there. Also, there is insulin sensitivity is disturbed in these population. And also to note that the non-esterified fatty acid oxidation is happening in the females during exercise rather than the glucose oxidation. This contributes to the increased 2-hour postprandial glucose levels in the females. This slide I have just borrowed from Dr. Usha Sriram Madam's lecture, because I found it is one of the beautiful ways in which we can depict the sex disparities by diabetes occurs. Again, regarding the development origins of adult, we are seeing the gestation progressing towards childhood, puberty, reproductive life. So many aspects we should educate the mother, because educating the mother means educating the family. So this is why we should tell them properly, you have diabetes, you have to manage the pregnancy properly. Also to note, I already told regarding vascular disease, but the vessel disease, even there also, there is additional risk of developing coronary artery disease. That is at least 60% more chances in the women than men. Stroke also more than 40% more value than the men. Even dementia or not able to remember properly, that also can be high in the females than the males. Vascular dementia or the reason for stroke, they can also be high. So put together all these complications, though they are seeing patients which diabetes may be less in females, the complication burden, the risk of developing them in the higher risk are more in the females. End-stage renal disease, or that is the only thing which has not been related in both the population. Then cancer registry has also shown endometrial cancer and breast cancer data that they are also having the higher risk because the women having the hormonal disturbances, even more than the testosterone issues like prostate cancer. Even that, we can see diabetes is not a major thing. So cancer issues also, there is an additional 27% in the women, whereas 19% chance in the men, which is why we should focus on the sex differences in these lectures. What about the metropolitan cities in India? Because the stress factor are seeing, so we are seeing that data is incidence of diabetes, mortality, and BMI. All these things have been studied by Sanjay Kalra sir and group. So lifetime risk is definitely higher for the women. Again, every aspect you are seeing that the diabetes in women is conferring a higher lifetime risk in across the population. So I have emphasized you in the first section that it is an important aspect because now we have got information in minutes and even seconds. So awareness of women's health is crucial for the community. And we have also come up with endocrine awareness initiatives from the Endocrine Society of India to help you also reach out to us through various social media networks. So I have considered all these in my discussion. So coming to the last part, which is the special considerations. So women also need to be educated on the aspect because in 1 in 7 births are affected by gestational diabetes. We have to protect the mother and the child by improving access to health. So this is an important slide which shows you the risk factors which we have to screen. We have to screen those with overweight, obesity, women with polycystic ovary syndrome. Already I have told high risk race because we are seeing we are a high risk for all these. But even more than us, there are other populations like the Caucasians. We are seeing so many populations our ethnicity have got a higher risk. The history of cardiovascular disease, hypertension. We have to ask the person correctly how they had an issue, how they died, then only we'll understand. First thing related with diabetes. Also remember that some other conditions will have insulin resistance. We have to identify those by screening. So there are so many socio-cultural barriers which we know. Obesity is not considered as a very prominently or priority. They visit less to healthcare professionals. They spend less time also. They are granted less time for exercise. Even social norms also are there regarding exercise, but now I think there are so many things which have been broken. I think the main thing is that the women are bagging more medals and only medals in the Olympics, which shows you that they are breaking the shackles now. Changing the diet is also very difficult because they insist that family meal is the one which they insist. So, which is why when a person comes with women with diabetes, we have to tell them that you are actually not different from others. We have to give them the same priority. So which is why the social determinants have been studied by the educational groups, the family income, the employment stage, the community, the dependency, the housing status, social support, education, even childhood experiences also count because they are a traumatic experience in the childhood. They can itself cause so many issues in the future. Also, the access to health, because if you have a good quality government health center nearby, that is equivalent to a high corporate hospital because they can give you affordable and accessible health also. The recent the IDF also told that access to diabetes health is a very important aspect. Even with 100 years of discovery, insulin is also not accessible and costlier for the people requiring them like type 1 diabetes. Even oral medicines may not be afforded by some population, and even self-monitoring by glucose meters, they have to be given properly. So it is actually should be shifted from the community health because in India we know insurance is not covered in the outpatient center. We should also have healthy food culture and it's a safe place to exercise because with diabetes, we know they have to give because we are seeing flats being built, so many villas being built without considering the areas where they can walk also. So now we are going to focus on gestational diabetes. Gestational diabetes focuses on the diabetes diagnosed during pregnancy. So many hormones are there by the placenta or the child gets from them. Gestational diabetes has got the mixed features of hyperglycemia, insulin resistance, and metabolic disorders. They all affect the risk for the diabetes progressing also. There is also a risk score for type 2 diabetes. If you have time, please can go through this. You can take a screenshot also, or you can get the data from the ADA website. So this gives you the checklist of various aspects where we can screen regularly. with diabetes. So I think this is very important for the non-government organization to screen populations, because they need not be given doctor's help also. They can even just check from the records or from the verbal records itself. Height also has been given an important priority because in BMI also. In pregnancy, there is a specific targets also described. They are different from that of the normal diabetic people. The fasting glucose has to be kept as close as 95, 1 hour value as close to 140, 2 hour value less than 120, and without any undue risk of hypoglycemia. Because if you produce a low glucose value, that can also be bad for the pregnancy. This is from the latest Diabetes Care Journal. A good publication had been given from the HAPO group, hyperglycemia and adverse pregnancy outcome. This studied from US. This shows you that these targets are realistically achieved by giving them insulin therapy. So self-monitored glucose is recommended in all women. We should do a fasting value, a pre-meal value, a post-meal value, or 1 hour or 2 hour value, and also the early morning value at 4 a.m. So they may ask you, when am I going to sleep? So we all tell them in pregnancy, the baby is also not active. Baby is always active. So you also have to remember to check your sugars. So which is why we should always insist on vigilance or awareness also. Practically, we do a 7-point profile in the hospitals, but at home, we ask them for a 4-point profile. These 4 times we should do them daily. Now the things have improved because last several years we are getting continuous glucose monitoring devices available, which a patch is inserted on your upper arm and you can monitor or measure by sensor. The Bluetooth sensor picks you and the glucose values are seen in the iPhone or in the reader. So this is called ambulatory glucose profile. This technology has also helped women to avoid the finger prick technique. Even the type 2 diabetic or type 1 diabetic individuals can benefit from the continuous glucose monitoring. So I have been lecturing you about gestation diabetes, but this is what diabetes actually does. It insufficient production of insulin, and there is also an increased resistance to the insulin in the body, which means that the load is fluctuating and we have to give short-acting insulin as well as long-acting insulin in a physiological manner. We should not give twice daily insulin in pregnancy because they can have high and low, which can produce. There are also time and range targets described for diabetes populations in pregnancy. This beautiful diagram shows you that we should have target values of good control in type 1 diabetes as well as pregnancy diabetes, even more than we have control for the type 1 and type 2 diabetes and even older or high risk individuals. In pregnancy, we don't take any chance, which means that we traditionally stop whatever the tablets the mother was previously taking, that is oral anti-hyperglycemic drugs. Sometimes metformin is continued because that is a debate in itself, because in polycystic ovary disease, that is the only drug which can be given a try. Adequate hydration should be given, complete at least 2 liters of water should be given, and we should insist on maintaining the glucose value in the range. Sometimes in the labor room, we are also seeing people receiving insulin infusion to keep the targets. And this is why we should always keep on the side a dextrose bottle ready with insulin to prevent the hypoglycemia. They are the good practice which have to be done in the clinical setup. In pre-existing and over diabetes, in the after delivery, they may need insulin, they may need therapy, but definitely we can traditionally require modifications, and the goals can be a bit higher in those which have been already been described. In after delivery, postpartum gestational diabetes, we can definitely stop the insulin or the oral diabetes, but we should give them a monitoring of at least 2 to 3 days while in the hospital. And at the follow-up period at 6 to 12 weeks, we should insist on them getting a 75-gram oral glucose tolerance test, which is a simple technique which can diagnose diabetes. So I have given you the management of diabetes in pregnancy in a very single table. Metformin can be used with caution in lactation by nursing, because in caution only, but if it is okay, we can give. Sulfonylureas, definitely some safe drugs are there among them, but definitely we give better agents like other available drugs. Some drugs like gliptins can be tried, but definitely we don't know about their toxicity, so we use with caution only. And we also know drugs like pioglitazone have been already been used previously, but again with only caution they can be given. Definitely a no to the previously given or already taken GLP-1 RA, because they are the ones which can result in vomiting and other issues in weight loss. This can be bad for the mother because their baby needs nutrition from the mother. Also remember that there are so many trials being gone, but still SGLT2 inhibitors or the newer drugs have not been given use because they can have the risk of developing injury to the developing kidney. So polycystic ovary disease has also changed the women's health paradigm, because we previously thought that now the science has progressed. There are multidisciplinary approaches, endocrine aspects, gynec aspects, dermatology aspects. So many things have to come together, which is why once we diagnose them at young age, we should give them a great follow-up so that they can be given a proper metabolic health outcome. Metformin is one of the major drugs used for improving the ovulation induction in women with PCOS, and this has got improvement action. Traditionally, it has got additional effect on the ovarian glucose pathway and also ovarian androgen secretion. Metformin is a wonder drug, and we have been using them in all our patients with diabetes and PCOS. And most of our patients have got toleration, and we are seeing that these have got multiple actions described. So from the teaching from the American college says that it is a very good drug. It should be used as first line or combination. As low as 850 milligram daily can be given in the even in the lean adolescent, because metformin is told to be an anti-diabetic drug, but it is also used in a proper labeled form in polycystic ovary disease. In overweight adult individuals, they can go up to 1.5 to 2.5 gram daily. So this is how the transgenerational karma of PCOS, gestational diabetes behaves. Fetal programming can occur in pregnancy, and we are seeing that this can result in childhood obesity and pre-metabolic syndrome, and even later on going in for early aging and type 2 diabetes. So we should always include a lifestyle advice as a prescription along with the weight control and proper screening. We should always give them lifelong screening for diabetes production and pre-diabetes at least every 3 years. This is from the recommendation. We usually ask them to do at least a glucose value at home every year. So whatever I have talked so far has been scientifically proven and scientifically based, but what we are seeing now is so much social media awareness. So this is a very interesting published in the Economic Times. We are seeing that so much survey has been done on how diabetes is awareness, but most of the women in pregnancy or in diabetes, they actually don't seek a specialist when they are required, but they consult their friends first. So the 35% is not a small number. Again, some of them admit to lack of exercise in daily life, and they actually have not themselves examined for diabetes, and also even in regular medical checkup, they agree that it's a must to control diabetes. This is a paradox, and despite all them, 20% actually tell them that they are having eating habits which are irregular. They are not cognizant of pre-diabetes. They don't know what is pre-diabetes, and also hesitate to adopt healthy lifestyle changes. So this is why more the number of people which we are spreading the message across, the better for our community. The last note about the infections, I was told that a lot of people were curious on diabetes and infection. Some infections are common in women also, like bladder issues, urinary tract infections, kidney disease also. Some having stones also can have a more risk because the proper hygiene is also required. I'm not telling the women don't have hygiene, but traditionally there is an issue because the vaginal mucosa is having other macrobacteria, healthy macrobacteria also are there. We should always try to clean before testing the urine also. Also, proper hygiene to be given by giving because we know that the anal orifice and the orifices have to be properly checked, and the cleaning should be done in the forward manner. And also, sexual dysfunction is also one entity which has been described in diabetes individuals. So infections in diabetic individuals, Escherichia coli is one of the major causes. And this is a strain which is having immense importance because they are there to the way resistant to management. They have to be checked for the urine culture also sometimes. So despite proper hygiene and proper techniques, they still can recur the same individuals. Some people who are prone fungal infections, they can have a secondary complicated urine infection also. Some drugs like SGLT2 inhibitors have got increased risk of urine infection because the person has to be educated about the urine, taking proper water and proper hygiene. And some individuals who have the risk, they should be counseled against taking this group of drugs. Sexual health, again, some organisms like Candida albicans have been described. This is the budding yeast, which you have seen. So there are healthy microbacteria or lactobacillus community and the strain of Candida albicans virulence. There is a shift in the balance between these two. And also I have told you behavioral factors, genetic factors, immune factors. A proper control of HbA1c has to be insisted when we are treating these people. Also, people with diabetic also have risk for developing diabetes mastopathy. It's a rare complication of diabetes long-standing. It is a fibro-inflammatory disease of the breast. It is a premenopausal woman. They develop a firm, non-tender lump, which is benign. Sometimes they think it is cancer, but definitely when they go for screening, it is found to be very safe to be left like that. In menopause, early menarche and early menopause can risk of incident diabetes. Depression is also very prevalent in the perimenopausal diabetic woman. These things risk to the transition. Even in now we are seeing cardiovascular disease in women is high because they are understudied, under-recognized, and underrepresented in the clinical trials, which is why we should, because we have to insist them to be properly screened for, because the physician bias also may be there. They may not insist on the exercise test to be done in the women also. Even bone density is also affected in diabetes, and that is also important in these factors. In type 1 diabetes, studies have proven that it's a complication, and an increased risk of fracture is seen in those women treated with thiazolidinedione than men, which is why this group of drugs can be kept as caution in these populations. Increased risk of hip fracture is seen in diabetic women than the age-matched women with that. This is all scientifically proven. So we are having discussion today focused on achieving glycemic control, giving them proper nutrition, educating them through the school as well as in our syllabus in every time, everywhere, and also screening them for complications and providing them comprehensive preconceptional care. Preconceptional care is done prior to pregnancy planning, and just like we give fitness for the surgery, we should also tell them they are fit for pregnancy by recognizing the pre-pregnancy health behaviors and risk factors. These are the risks which not proper control can confer. And we have to work together because a multidisciplinary team is ideal. Endocrinologist, a fetal medicine expert, a registered dietitian, as well as diabetic educations. These are all important to manage. We should also insist them receiving the proper immunizations like rubella, the varicella, hepatitis B, influenza. These are all important vaccinations. Also, we should ensure that the family plan is there because the nutrition and medication plan should be counseled. Those who are type 1 diabetes have to be told that the option of pump also can be given. Continuous glucose monitoring can be beneficial in the pre-conceptional period. I would like to give you 6 tips for pregnancy with diabetes. The first one is to try to achieve HbA1c control of less than 6.5% at least 3 to 6 months prior to conception. Try to switch the oral medications to insulin to prevent the risk for the fetus. Evaluate for retinopathy and nephropathy prior to pregnancy. Blood pressure, regular monitoring, and control them with a different group of drugs than the traditional medicines. We should stop AC inhibitor, ARBs, or androgen receptor blockers and diuretics when pregnancy is planned. The safe drugs are labetalol, methyl-dopa, calcium channel blockers, and alpha blockers. We should stop drugs like cholesterol medicines like statins and fibrates when pregnancy is planned because their risk to the fetus embryo and cartilage is already proven. 5 milligram of folic acid for at least 3 months prior to pregnancy is a very important practice to be given. So dear friends, I have tried to simplify discussion There's always a chance for shared decision making. The partner, the person who is living with the person with diabetes has to be given proper education also. There are still issues which need to be addressed. These are the various aspects I want you to think, because I have seen a recent case where insulin was underused by the woman because social obligations, housewife, homemaker had some, they neglect their health. Working women may spend more time for their children than their own health. So this is a concluding optimism from my side. We should try to prevent the gender-specific issues. We should try to address the issues with diabetes, can, proxima. In the holy month of Ramadan, because the person can be fasting also, there can be a risk of getting high hyperglycemia and hypoglycemia in this. So this is why we should monitor them more vigilantly in this respect. So I have tried to give you aspects regarding universal screening in pregnancy, selective screening in pre-existing diabetes, also in gestational diabetes. It's an opportunity for you to control them properly and prevent the diabetes, obesity, and premature cardiovascular disease, because long term we can definitely help them in their population. So we have giving them healthy start to give them uneventful journey, and giving them a good outcome is our ultimate aim. So I would like to thank all my friends for giving me their help, acknowledging the contributions from Dr. Sanjay Kalra from Tanna, who is my mentor. He is the person who is behind the endocrine awareness initiative. Dr. Nandini Prasad, who was kind enough to share the slides with me. So I was very fortunate that she shared the slides regarding gestational diabetes with me. But Usha Sriram madam, very fond of women empowerment and women diabetes. She's founder of the Women's Health in Chennai. Dr. Jayagumari madam from Trivandrum, one of the very famous teachers who has lent her ideas to this. Also, Dr. Rajapal, who is also listening to us today, he has given me at short notice a few aspects of diabetes which has been used in his clinical experience. Thank you, sir. And also Dr. Nalini Kopale from Hyderabad, who is a fitness freak. She has given me insights on nutrition and fitness. So thank you all, because I am only because of my friends. Thank you for the attention.
Thank you, doctor. Indeed, great presentation as usual. I have a couple of questions, like how many questions we can take now?
Yeah, I have overshot the time actually, no? I have given more time as actually.
5 to 6 questions, if that is
yeah,
okay.
Yeah,
sure. Doctor, the first question is, can I take chapati than rice?
Well, that is a thing, because whatever we eat has to be given proper calorie monitoring. So what about, not about the wheat or rice? So this nutrition has to be given from the proper nutrition point, because whatever we eat has to be monitored. Because chapati is told to be good because the calorie produced spike is traditionally less, because we eat less of chapati, South Indians. But when you go to the North India, the Punjabi population get more of chapati than they also have diabetes. So it's not about chapati or rice. It is in moderation. Whatever we eat, we have to have the proper diet. It is not about the diet selectivity. It is specificity of the diet.
Thank you, doctor. The next question is, can I take sugar-free regularly?
Yeah, this is also good, because sugar-free, aspartame, stevia, we are seeing sucralose. So many drugs are already, so many things are there. This is only to give you a taste of sugar. They are not actually giving you any what I call benefit of diabetes control. Just to give you the pleasure of the glucose they are giving you. But I traditionally tell them, if you are comfortable, you can use. But some reports are there about bladder cancer, and some reports are there about the predisposing to other issues. So some issues have been traditionally taught as taste issues. So I think it's left to the individual to decide. Doctor can definitely guide you in the choice of the sweetening agents. But what I can say that nowadays we are finding people who are interested in monitoring the glucose value. That is more important than consuming these artificial sugar or the sweetening agents.
Thank you, doctor. I have PCOD. Do I have to check my diabetes frequently? If yes, what will be the days?
Yeah. So PCOD or polycystic ovary disease, I think it requires a lecture by itself. A polycystic ovary disease can produce diabetes through insulin resistance, and we can definitely prevent diabetes by controlling the body weight. Even there are lean PCOS or those who are normal body weight, they can also have PCOS. So I think whatever I have told today is to control the diabetes, and once diabetes is there already there, they have to check them very frequently, because when the HbA1c is going beyond 7%, they have to be given additional drugs just like any other diabetic individual goes. Only thing, metformin is the mainstay. Metformin doses can be given in a very high dose in polycystic ovary disease. So just because you have polycystic ovary disease doesn't mean that you can be treated like diabetic individual. Diabetes risk is always there in PCOS, but it can be overcome by lifestyle modifications and meeting the doctor regularly and taking the proper calories in their diet. So whatever diet we are using, we have to give them in a correct meal planning also, because the person who is using the problem, because meal time of the person is important. Sometimes the noon may be heavy, sometimes the night food may be heavy. So according to that, we should give the proper agent in the treatment plan. So we should discuss to the doctor, then only suggest taking the proper medicines also.
Thank you, doctor. Uh, Diagnosed with diabetes and I feel hungry all the time. How can I suppress the hunger?
Yeah. So hunger suppression is a very difficult thing, because I think suppressing hunger may not be a good idea sometimes, but there are some appetite control mechanisms available. Drinking more water may be one of the ways in which appetite can be reduced. Hunger is different from appetite, because hunger means penchant for having food, because that the tolerance for food is less for those who are very hungry. So we have seen advertisements for hunger, but hunger, appetite adjustments are not there. Appetite can be regulated by three things: willpower, water, and giving more of workouts. So if you are giving more workouts for the person, it can be mental workouts, physical workouts. We can definitely try to reduce the appetite. There are some medicines which are available to suppress appetite, which are beyond this topic also. But definitely the doctor who has been managing them, there are some hypothalamic agents which have been used to suppress appetite. Hunger may be the side partner of appetite, because if you are suppressing appetite for a long time, it can also be bad. So anything which is more is always bad, which is why appetite suppressants can definitely be a bad thing to be used in the long run.
Thank you, doctor. The next question is how to manage DKA of menopausal women. I think
Diabetes, huh?
yeah.
Yeah. So in menopausal women, diabetes is managed just like in other premenopausal also. The difference is that these have got risk for psychosocial issues, and we have all seen that some menopausal ladies can have bone fractures also, bone issues also. So we should choose agents which are safe for the heart, safe for the bone, as well as for the mood also, because we should not insist on the same medicine to be taken correctly, because in those individuals, we should give flexible meal time, flexible medicines. We should give them an opportunity to interact more. I usually give them option for telemedicine also in menopausal women, because that is one of the ways in which their concerns can be more told, because the hot flushes is one of the major things which I've been seeing. Hot flushes mean there is the vasomotor symptoms. The face can have high heat like sensation. That is actually a bad thing, because that can be neuropathy also can occur. So addressing the complications of diabetes has to go side by side with the menopausal symptoms. So we should not use agents like pioglitazone in these individuals, because the bone fracture risk is high, the weight gain risk is high, also the heart failure risk is also high. Among insulin is very safe to be used in menopausal women. Only thing we should insist on lifestyle modification whenever we are giving prescription insulin, because that can also give risk for the weight gain also. Other drugs can be used, sulfonylureas, the metformin, other drugs are very safe to be used. Only remember that we should use safe for the heart also. Thank you.
Thank you, doctor. Can we take one more question? Doctor, the next question is, can you brief on eye care in diabetic patients?
Right. I have not told much about that. Eye care is one of the things which is it about eye only? No, they told eye. Yeah, eye is very important because eye is the window to your mind also. Sometimes, whenever you are seeing the eye which is bright, we are seeing sometimes the person is active. So I think eye means we have got three layers. That is retina, the cornea, as well as sclera. So cataract is the one which is more common cause of blindness or preventable blindness. But in diabetic individuals, there are three other causes. One is retinopathy. Retinopathy can itself cause risk for progressive of other risks because hypertension, other things can also correlate. Retinopathy means retina layer gets inflammation, and this needs to be given sometimes proper timely treatment. Otherwise, you can lose the eye also. This is actually not time preventable because only screening can help you in preventing that. Then you have glaucoma. Glaucoma can be painful and they can even they can painless also. They can also lead to sudden loss of eye. So this can be angle closure glaucoma or narrow angle glaucoma. So there are other causes like retinal detachment also. This can also be a risk in diabetic individuals. So screening is the only way. You should use dilated fundus examination. You should use a proper medicine to dilate the fundus. Some medicines are there, glycopyrrolate as there. So very safe to be used. The person can drive later after 4 hours, and a person can definitely check the eye specialist can check the fundus. We have been trained in examining fundus in our DM as well as the training of the period. So, but still I insist on ophthalmology person to annually check the fundus examination. I think that requires another class by itself. I think I have given you a gist of it.
Thank you, doctor. I think maybe what are the questions coming in, we'll take it later and maybe we can come up with other session.
Yeah. So always welcome.
Yes, we may not be able to cover all this topic now. So on behalf of MedPiper Technologies, JournoMed, IWN, we would like to thank Dr. Shenoy for spending your Tuesday evening with us in detailing each and all aspects of diabetes in women. Thank you, doctor. Looking forward for more collaborations with you.
Thank you.
Thank you.
Safe time, everybody.